So we know that an undercurrent of workplace violence has challenged providers and frontline admin staff for years. And as the pandemic stretched on, our CNOs expressed concern about record levels of violence impacting care delivery and the workforce. So it was clear the industry was looking for a roadmap forward. And today I'll share some of this research with you. So I know most of you are familiar and aware that we have a violence problem, with about 75% of workplace assaults in the United States involve healthcare workers, and nursing staff are especially vulnerable, and the majority of these incidents go unreported. And some health systems historically scope out lateral violence, which is also known as bullying, but we included this in our definition and our research to demonstrate a zero tolerance towards any type of violence. And oftentimes, if you see on the right hand who is involved in workplace violence, there's a focus on patient or family member committing violence towards a healthcare worker. But it's important to note that employee-to-employee violence, from name calling, intimidation from senior staff members, is just as impactful on psychological safety and folks' willingness to work in the healthcare industry. You see that the model has 3 maturity levels: foundational, proactive, and optimized. And underneath those, if you see the blue boxes, there are 5 domains: governance, prevention, timely response, timely reporting, and aftercare. So health systems can use this model to assess their organization's current state of workplace violence, prevention, and response, and decide what concrete steps are needed to make progress in terms of their workplace violence maturity. And while governance is truly the backbone to workplace violence strategy, health systems can only be accountable if these processes are standardized. So when speaking with our health system leaders, we identified 4 key challenges when it came to governance. So the first being there was no comprehensive definition across the board, which we've touched on already. Policies that were limited to acute care settings. So we often know that acute care settings get more resources when it comes to workplace violence strategy and prevention, leaving non-acute care settings at risk. And especially as we look to move to hospital at home and shift to ambulatory care, we need to strengthen these policies. Then also the third challenge being varying committee and authority levels across the board, and who is able to uphold these policies. And the fourth challenge, limited capacity from government affairs folks and limited lobbying opportunity. So when we think about prevention, that includes education, training, risk identification, and security measures to mitigate violence and to offer a safe workplace. So when this is done well, we can reduce the number and severity of incidents, which in turn reduces costs, workplace injury, absenteeism. And when we think about prevention, health systems are relying on foundational solutions that frankly aren't that effective. So when talking to our health system leaders, again, 4 challenges came to the top. So the first being, at best, minimum education. So annual education often fails to include lateral violence, and staff are uninformed of the aftercare services that are around, especially after an event occurs. The second being training being limited to high-risk units. When we think of high-risk units, we think of ED or even behavioral health units, and de-escalation limiting only to those units and non-existent for non-acute care settings puts healthcare workers at risk because they don't have the tools needed to understand and de-escalate a specific event. The third being a few utilizing risk identification alerts within the EHR to support these flags. And then the last being using solely signage as a singular prevention tactic, which is not effective. So almost every system we spoke to has, and all folks on the phone as well, has some type of incident response strategy in place. So I do want to recognize that, but many feel that they're starting to make headway in this area, which is exciting. So similar to the prevention, when we think about some of the challenges, having a limited rollout of wearable devices, often due to a limited budget to purchase devices to protect staff, is something that folks mentioned is a barrier. And then the second being structural and communication barriers which oftentimes lead to an increase in response time. So when we think through siloed care teams, insecurity can result in these strange relationships, which can increase the amount of violence. So timely reporting, our fourth domain, is a key function that helps leadership not only understand workplace violence trends, but informs data-driven solutions to prevent these incidents. So when we think about what does that look like, on the right-hand side of your screen, having a protocol that includes different types of violence, being verbal, physical, and lateral violence. Again, that's bullying between coworkers. Staff education on the workplace safety and reporting protocols, having a reporting system in place that's Joint Commission compliant, that is also aligned with other reporting. When you think about patient safety event reporting, that's a great example. Having the data analysis, and this is a key component, to have incident reports reviewed by quality and patient safety teams to really understand who is involved, what's going on, are there trends that we need to be aware of that we're not currently aware of? And this reporting and data is really the key way to do that. And then having that internal reporting regularly shared with leadership, because at the end of the day, we can't keep these results in a vacuum. These results need to get all the way up to our C-suite leaders so they can have a sense of what's going on and allocate the appropriate resources. But beyond a standard reporting approach, health systems need to change their culture of reporting. And currently, nurses and other staff view workplace violence as part of the job, and that needs to change. So while most health systems have some type of aftercare in place, most are looking to completely overhaul their strategy to standardize support services and protocols. So when you think about what does aftercare look like, what are the key components, one of them is having a post-incident debrief. So again, taking some lessons learned from patient safety events and thinking through, let's say, the RCA structures, to have staff and folks involved to have some type of mediation and to really understand what's going on, and having that report sent to the Workplace Violence Governing Committee so they can have the data that they need to make changes and to allocate the budgets. The second being trauma support for staff involved. This is being involved in this incident can be very traumatic, and we want folks to feel safe at work. So we need to provide them the short and long-term services to get through some of the trauma after experiencing one of these events. Workers' compensation, having OSHA compliant policies, and then legal response to support staff if they do want to pursue that route. So similar to, we've talked through all the other 5 domains, some of the challenges we heard from some of our nursing leaders was the first, again, being that inconsistent post-incident debrief. So these informal processes are in place in many health systems of how to investigate what occurred, but having this inconsistent procedure of whether you debrief for acute versus non-acute care settings can be very confusing, and you don't necessarily have a real sense of like what truly happened and what were the system failures that we could have prevented. And then the second being limited trauma services. So staff only oftentimes are provided with short-term trauma support. So maybe a session with a psychologist or a social worker in the week or 2 weeks. But if someone has hurt you, that can last a long time, whether it be physical, mental, or emotional pain. So we really need to think about how we can support staff in the long term. And in 2020, major health partners wanted to improve staff safety by decreasing response time to workplace violence incidents. So David, what were some of the challenges MHP were facing to support caregiver safety?
So, despite all that we've implemented, we still have challenges. The challenges we face are timely reporting in general, and the speed of security response to those events. So, we felt that if we didn't face the challenges and determine how to rectify them or change them, then we were creating an environment where staff felt that we were okay with a certain level of workplace violence. We recognize that if staff feel like they are just supposed to handle the workplace violence on their own, then we would see greater numbers of dissatisfied staff and higher turnover. Just the pandemic itself, we were placing restrictions on not only patients but visitations and families and visitors altogether. So that was increasing the amount of anxiety from that standpoint that kind of was felt among staff members. So there seemed to be a lot of displaced anger, even at the patient level. So there were increases in workplace violence. And it wasn't necessarily just physical, it was that verbal kind of onslaught, verbal abuse, intimidation, inappropriate behavior. So yes, we were approximately 3 to 5 events, and that kind of creeped up as the pandemic went on. We started noticing more and more workplace violent events. So we recognized that with these events, we needed timely reaction to them in order to de-escalate them and oftentimes hopefully prevent them from getting any worse.
Thank you for watching this webinar preview. To watch the full version of this free on-demand webinar, follow the link in the description. Thank you.